Hey, okay, we are live. Oh, wait, 4 to 5 minutes. Hi, everyone. Thanks for joining. We'll just wait a couple more minutes. Hello, and welcome to tonight's webinar on MBS item numbers for older persons in the community, including case conferencing. Thank you for taking the time to be here with us this evening. My name is Hoda Sanai from the Sydney North Health Network and the Northern Sydney Local Health District. The Sydney North Health Network wishes to acknowledge Australia's Aboriginal peoples, the traditional custodians of the land on which we meet and work. We pay our respects and recognise their continued connection to land, water, and community, and honour their ancestors, elders past, present, and emerging. And we extend that welcome to anyone present with us this evening. Couple things before we continue. Your microphone and video will be disabled during this webinar. If you would like to change your display name, you can do this by clicking on the participants icon at the bottom of your screen, clicking more, and then you can change your name by clicking rename. If you wish to interact with each other or submit any questions, please do so via the Q&A box, which you'll find in the controls panel at the bottom of the window. Just click Q&A and please type in your questions and they'll be monitored throughout the webinar, but we'll also have some time at the end to collect some of those questions and have some answers. The last thing I'd probably share is at the end of this webinar, we will be sending out an evaluation survey. The link will be sent to you tomorrow, but if you can spend some time in filling that out, that would be great for our continued improvement. Quick slide and information on Health Pathways. Health Pathways is an online health information website which supports GPs, hospital doctors, nurses, other practitioners, pharmacists, Ally Health, and other clinicians. It essentially launched in 2017 and has grown to support clinicians with over 450 local health pathways established, providing over 10,000 page views per month. It is a really great tool to assist you in navigating local services and referral pathways to particular services in the Northern Sydney region. We will be sharing these slides with you all at the end of this webinar and tomorrow. So if you wish to have some further information on health pathways, we've put a video link here for you. And we've also outlined how to get connected to health pathways. Again, we will be sharing these slides. We have listed out some of the local services that you can access and refer to for your patients that are in that older population cohort. We've listed out the name of the service. We've listed out when to best use the service, eligibility for those patients, and the local referral details. This particular slide outlines those services that are in the non-urgent category or path of the patient's journey. So those that are needing that acute care. And we have also listed out here those services that can respond at a potential time of crisis. So for tonight's webinar and learning about the MBS a little bit more, we have a few learning outcomes. The first is to identify and manage a patient or group of patients that are making recurrent presentations to hospital by utilizing available data and establishing team-based care through the use of available resources. The second is to utilize appropriate MBS item numbers to ensure provision of support through referrals to allied health services appropriate to the patient's needs. The third is to identify health concerns with the elderly through better understanding the MBS system and the numbers you can utilize. The fourth is to outline effective referral pathways and options to ensure continuity of patient care. I'd like to introduce our speaker for this evening. Our speaker is Wendy Omer, Primary Health Education Consultant. Welcome to anyone who has just joined. Please use the quick Q&A to chat, but I'd like to now introduce Wendy. Over the past 23 years, Wendy has worked in all aspects of general practice, including reception, practice nurse, and a practice manager, and has a strong, comprehensive understanding of all facets surrounding each of those areas. Wendy currently manages 15 reception staff, admin staff, 5 chronic disease nurses, and is responsible for IT, daily operations, and induction and mentoring of new GPs and medical students, along with accreditation preparation for her current practice. Wendy has developed a strong interest in Medicare interpretation and chronic disease and has excellent understanding of the guidelines and how to maximize it within a general practice setting. So we welcome you, Wendy, and thank you for your time.
Thank you so much, Hoda, and welcome everybody to tonight's presentation. Thank you so much for taking time out at the end of, I'm sure, a busy day in general practice. So I hope that tonight I can share with some information to you or to help you to better improve things. So the aim of tonight's presentation is basically what we're looking at is trying to educate the participants in the many item numbers that the MBS provides to general practice to provide care to the elderly in our population and to hopefully prevent recurrent hospital presentations. I'd like to touch on, I think, the effects of COVID-19. As you know, the elderly have been severely impacted by COVID-19 with isolation and, of course, a reduction in social interactions and physical activities that they have experienced, mainly due to lockdowns and restrictions. But also, the chronic disease management in general practice did have to be put on the back burner because we were dealing with vaccinations and every day things were changing. So the chronic disease management of our patients was sort of put to the back. So we now need to re-engage our patients and try and improve the outcomes so that we can get patients living independently with great quality of life. So there's lots to cover tonight. And so I'll get started. So basically, I won't go through the learning objectives because Hoda has very kindly done that. So thank you, Hoda. So first of all, I'd like to look at a little bit of data. I won't spend too much time on this, but I sort of like to put things into perspective a little bit. So within the Australian population, as of June 2020, we had 4.2 million Australian residents over the age of 65. And more than half of those were in the 65 to 74 age group. 2 in 10 were aged 75 to 84 and 1 in 8 were over 85. However, by 2066, which is not that far away, we are expecting a population of over 8 million Australian residents over the age of 65. So that's a huge, and it's just growing every year. Basically, older Australians are presenting as an increasing percentage of our population. There is a high percentage of women. And in New South Wales, you have 17% of your population over the age of 65. Over 65s account for 16% of all hospital admissions and 53% of extended stay episodes. So this is what we're trying to look at tonight, some strategies and some programs and some opportunities for you to try to reduce those numbers. When we talk about hospital admissions, what we're focusing on tonight is what's called PPH, or potentially preventable hospitalisations. In Northern Sydney in 2017-2018, there were 22,000 potentially preventable hospitalisations. That's 2,062 for every 100,000 people in your state. The majority of the admissions were due to complications due to chronic disease, and falls were the main presentations. Of course, the other thing that has a significant impact on the elderly and is a high indicator for hospital stays is medication mismanagement. So we're going to look at those areas tonight and how, as general practitioners, we can put things in place for our residents. Just going back to the potentially preventable hospitalisations, these are the indicators. So as you can see, most of the conditions that you see there are what we manage in general practice every day. So the chronic conditions, so your asthma and your CCF, COPD, you've got your more acute conditions, so the patients who present with pneumonia, cellulitis, any of those, and then the other vaccine preventable conditions. So lots to look at. And we see it every day. So, and unfortunately, we are in the prime position to put things in place to prevent this. Just a little graph I like to show when we look at something as common as hypertension in general practice when we're treating our patients. As you can see, the age group for the highest incidence of hypertension, which is not really a surprise, is the 75 plus, with a huge spike in the 65 to 74 age group. So just alone in one, and even hypertension is not actually classed on its own as a chronic condition. The percentages are huge in that age group. So we know what we're looking at. We know what we deal with every day. Now we need to look at how as general practitioners or general practice staff, we can help our patients to prevent these admissions. So general practice is the front line of Australian healthcare. We are where the patients will attend first when they have symptoms or signs, or where they go for advice or education. We're critical in reducing the number of potential hospital admissions. 95% of all elderly patients regularly see their GP. So when I say elderly, I'm talking at that 65 plus age group. In fact, the ABS stated that there was at least one presentation per patient in every 6-month period. So we have our frequent flyers, so those patients who are regularly attending, but as a rule, most patients over 65 attend their doctors regularly. We're presented with things like falls, chronic conditions, medication misadventure, and as I said to you before, they are the largest contributor to hospital admissions. 2019-2020, 42% of hospital admissions and 40% of deaths were due to falls. So that's pretty significant. And when we look at falls, there is so much we can do. So when we go through the programs that I'm going to talk to you about now, you'll see that by referral processes and by getting our patients engaged in actively managing their conditions, we can actually prevent those things. So as I said, prevention is the key. Managing our patients' chronic conditions and risk factors is important, and it's so important to involve a multidisciplinary team. So we can only do so much as general practitioners or general practice staff. We then need to look outside our walls to find other available people to help our patients to manage their conditions. We can't do it on our own, but communication is really important. So being able to communicate with the team and know where our patients are at is really important. And I will talk about that with particular reference to case conferencing, something we don't do very well in general practice, and it's a real opportunity for us to improve things. So the aim of multidisciplinary care is to obviously improve the quality of life and to promote independence for our elderly Australians. So now that we know the what, now we're going to look at the how. So we're going to look at the common chronic disease services or programs available to general practice and how we can use them within our environment to refer our patients on to appropriate care. Before I start that, I do want to touch on this. So in general practice, what we aim to achieve is what's called the general practice sweet spot. And what that means is we try to reach the 3 of these equally. So we like to have appropriate fee for service, achieve positive outcomes for our patients, but also maximize our staff and the services that we can offer. If we can do all of those things, we have achieved that sweet spot. I do want to touch on the recent or the current press regarding the Medicare rorting. I know a lot of people will be concerned about that, and we will talk about that towards the end of the slide. And I'd be really great if someone would like to put a question, if they have any, about that and how it impacts us, particularly with relation to chronic disease, because one of the barriers to GPs performing chronic diseases, they feel that it's a bit of a rort of the system. So I hope I can alleviate or dismiss that fear tonight, but we will talk about that later. I think it is timely that we do mention it. So what's available to general practice when we look at MBS item numbers? So when you look at the far left, the first one is our 23 and 36. So for a 10 to 15 or 20 plus consultation, and if we bulk bill the patient, we receive a remuneration of close to $40 or $76 if we're looking at an item 36 or level C. However, If we look at the other chronic disease item numbers, there is a much larger remuneration for the same amount of time. So to have a 721 and 723 or management plan and team care arrangement in place, we're looking at a potential $273 for that same period of time, because this is where we get our practice nurses involved. Then we look at the reviews and, of course, the health assessments. I am really a huge supporter of health assessments, and I will explain to you why, but I think they are the most valuable tool we have as general practice staff or general practitioners to get the big picture of our patient. And, of course, the medication reviews. So as we know, there's a high incidence of hospital admissions due to medication misadventure. So these are the kind of things we need to be looking at to refer our patients on to actually get some assistance with that. So basically, the AAPM stated in the 2021 model of care for a patient with chronic disease, the MBS revenue for a single patient is around $905 per year. That is completing care plan and team care arrangement, reviewing it regularly, so 3 monthly if they're diabetic or someone who needs that regular review, a health assessment conducted once per year, and then other standard consultation item numbers related to the chronic condition. And you might note that doesn't include medication reviews. So if you include the revenue of a medication review, we're looking at over $1,000 per patient that is available to us. For managing patients, so we already manage them. So anyone who looks after a diabetic patient or a COPD patient or a patient with any chronic illness, you are already managing those patients, but are you being remunerated for it? So, as I said, I'm a huge supporter of health assessments. I think they're one of the most valuable tools we can use in general practice to get the big picture. And the best part about it is it's where our practice nurses come into their own. So our practice nurses can assist us in this process. So as I said, the most valuable tool we have in getting particularly new residents or new patients who are new to us, getting that big picture of their whole health. It encompasses all of the patient's general health factors, so physical, psychological, social, and allows us the consideration of preventative healthcare and education. So many patients come to us with conditions that they have not received education on, or they're not really sure how they manage it. So this is an ideal opportunity, being such a comprehensive assessment, to actually capture all that information. You can see there's lots of different types of health assessments, starting at the 75 plus health assessment, and I've also listed on the right hand side the frequency in which they can be claimed. So your 75 plus and your CMAs, which is equivalent for a resident of an aged care facility, they are conducted annually, as are the intellectual disabilities. One that's very rarely used. I'm not sure whether GPs just forget about it, but that's one that can be claimed yearly as well. Then you have the Aboriginal and Torres Strait Islander health assessment, which can be done every 9 months and is a great resource for those patients to help them to manage their conditions. You have 2 different types of health assessments within the 40 to 49 age group. And there's often a lot of confusion about this. So the first one is the type 2 diabetes risk assessment. And how that works is, if you see a patient and you conduct your OSD risk tool, which is in most of our clinical software, and the patient receives a score of above 12, they are then eligible, because they are determined to be at high risk of developing diabetes in the future. They are then eligible for every 3 years to have a 40 to 49 health assessment, obviously only in that age group. So if you identify a patient, for example, at the age of 40, you can then conduct the assessment at 43, 46, and 49 before they reach that cutoff period of 50. Because the research shows that that is the age where the prevention and addressing the issues, lifestyle factors and diet, have the most impact. Then we have the 45 to 49, which is available to every person in that age group. So there are no there's no predeterminations for that. If you're 45 up to the age of 49, you're eligible for that as well. And again, it's an at-risk one. So when you look at your patients and if they have high risk factors for hypertension, cholesterol, or strong family histories, they are the patients that we should be targeting. I will acknowledge they are one of the hardest age groups to attract. So I know within our practice, we have tried so many times to get a program running with this age group, but they're just so hard to get back. So if you get the opportunity to have someone sitting in front of you, grab it with both hands and use it. We do have the refugee and other humanitarian entrance, which is a once-off, and it's done within 12 months of arrival into Australia. And then we have the ADF, which is the returned or former serving members of the permanent or reserve forces. So again, a once only, mainly aimed at those who have left the service, and just to make sure that they're not at risk of things, particularly mental health and things like that. And then the healthy heart check, which is GPs and general practice as a rule have had quite a good uptake with this. But what I do want you to remember is if you do the healthy heart check, it is classified as a health assessment. So if your patient is 43 or 45, for example, and you just do the healthy heart check, you can then not complete another health assessment for a 12-month period, because it meets the criteria for a health assessment. And as we know, health assessments must be a minimum of 12-month intervals, with the exception of the Aboriginal Torres Strait Islander one. So, but the benefits to healthy heart checks is that they, as we know, can be done for anyone. So I think it's been reduced. I do believe it's now anyone over 30. So if you can't do them on an 18-year-old or a 29-year-old, but anyone 30 and above. So that allows us to capture that younger group. And I don't know who saw the paper today, but I think there was a 33-year-old gentleman who was a big hoo-ha about the ambulance service not getting to the patient in time, and he died of a heart attack at 33. So again, we need to start looking at prevention. Okay, but just a brief overview of the remuneration available. So as you can see, all of our health assessments are time-based. So less than 30 minutes, you would bill a 701, and that's your rebate, right up to your longest health assessment, which is the greater than 60 minutes, which attracts a revenue of $284.20. And then it also shows you the potential revenue for your Aboriginal, Torres Strait Islander and your healthy heart checks. So just an idea of what they are and when you can complete them. Now we need to look at the elements. So if we're going to do a health assessment, we need to be sure that we are meeting the MBS criteria for those to do them. You can't just say, yep, I'll spend 10 minutes with a patient and I'll quickly ask them everything I need to know about them, and then I'll bill a 707. Doesn't work like that. The very first thing you must do is obtain consent. You must explain to the patient what you're doing and why you are doing it. And then you need to document that they have agreed to participate in this. Then you need to collect the information. This is where our nurses come into play. And I know there's some nurses here tonight, so thank you for joining us. The nurses are brilliant at collecting that information. So they can do the interview with the patient, either using a template that's provided by the practice or something that's generic out there. And they collect all the information and do the interview with the patient. The collection of information requires taking a history. So not just about looking at what you have recorded, but asking that person, can you tell me about your history, your medical history? What have you had? What operations have you had? And what history, what history have you had of any illnesses, particularly both yourself and your family? The undertaking and arranging of investigations and examinations, if appropriate, so routine blood tests, things like DEXA scans, if they're prone to osteoporotic, FOBs and cervical screens, even in their age groups. So all those investigations come as part of that big picture. Making an overall assessment and then recommending appropriate action. So these are the shortened guidelines for the MBS. So this is what you must complete or tick off, so to speak, at the end of a health assessment. That's why you have so much time for it. And of course, providing advice and information to the patient, which is often as a result of the interview. You must keep a copy in the patient's record, and you must offer the patient a copy. They can decline, but you must document copy offered, patient refused, or copy offered, patient accepted, something like that. So that must be documented as well. And the criteria, we also talk about the assessment of the patient's health, physical, psychological, and social. So it'll cover all of those aspects. And when you're looking at things like medication mismanagement or social isolation, the ability to manage at home, these things are paramount. They are best done in the patient's home. Now, I know there's a lot of argument about that. We still do them in the patient's home. So I have a nurse, I'm very lucky, and I have a lot of chronic disease nurses. I have a nurse who spends 3 days a week going out and visiting our elderly patients in the home, because the home environment is what we're trying to assess. So when a patient comes to the clinic, they can present any way they want. They can present well-dressed and well-kept and in control of everything. But yet when you visit them at home, you're actually in their environment and you can see how they actually are managing. It's a consideration opportunity. So it's an opportunity to say to that patient, okay, after our assessment, I do believe there are things that I can put in place for you to help you stay at home longer or to manage those conditions that you're struggling with. The patient must be living in the community to receive the health assessment for the 701, the 700 item number. However, as you know, you can do the CMA, which is the aged care facility, but they cannot be in hospital. And as I've said to you again, the patient must have the process explained to them thoroughly before you commence. Now, with the Aboriginal Torres Strait Islander, a little bit different. So they are conducted or able to be conducted every 9 months. And there is no age restriction. So it can be an Aboriginal Torres Strait Islander of any age. They recommend 15 and above, mainly because they're the most able to answer the questions for themselves. But there is no age restriction on these health assessments. The aim is, of course, to provide care to meet the needs of each individual with any health assessment. But they found, particularly with the Aboriginal Torres Strait Islander groups, that it's paramount for the early detection, diagnosis and intervention of any chronic conditions. As you know, they are more prone to those conditions. And it also allows, by putting the health assessment in place, allows a further referral to other allied health services. So either 10 additional practice nurse supported services or Aboriginal health worker services if you have one employed in your practice. So it's a really good value add to the patient and to the practice. So something to think about if you have some of those patients on your in your database, certainly look at them and offer them the opportunity to receive this. The other benefit to conducting a health assessment is it allows you to identify eligibility for the enrolment in the Closing the Gap scheme, so the PBS funded scheme. So for those of you who are not aware what that is, the Closing the Gap scheme is a service or program available to Aboriginal and Torres Strait Islander people of any age who are registered with Medicare. There are no requirements. There were previously, as of 2020, I think, or 2021, that has been removed. So now any Aboriginal or Torres Strait Islander person can receive the health, can register with the Closing the Gap. You can register through PROTA. So gone are the days where we had to fill out 20-page forms and fax them off and hope that someone received it, and then they send it back to us because we missed a box or the information wasn't right. So now you can actually register them straight away through to your practice. Your practice manager can do it on PROTA. However, of course, the patient must consent to that. And there is an incentive to practices to actually sign these patients on is a once-off payment of $1,000. So each person or each Aboriginal or Torres Strait Islander that you enrol in the Closing the Gap scheme, you are eligible for a single payment of $1,000, plus you have ongoing yearly payments that are in a tiered system. So I believe it's $250 per year. And then there's other tiers as well, whether you manage the chronic disease. So whether you're generating chronic disease item numbers as well for those patients, it flags for further payments. So to be eligible for the Closing the Gap PBS, the determination has changed as well. As I said before, they used to have to have a chronic condition. Now it's all about the management of their medication. So basically, the eligibility clearly states that the patient, in the opinion of a prescriber or Aboriginal health practitioner, would experience setbacks in the prevention or ongoing management of their condition if the person does not take their prescribed medication, and are unlikely to adhere to a medication regime without the assistance through the program. What is the assistance? So basically what it does is provide anyone enrolled in the program with either free or subsidized medication. So By free, any Aboriginal or Torres Strait Islander patient who is on a healthcare card or pension card will now, on a healthcare card will now receive the medication for free. And anyone who's not on a healthcare card or pension card will receive it at the $6.20, or I think it's $6.20 instead of paying full price for it. So it's an incentive for those patients to take their medications, particularly things like diabetes or asthma, it's sort of an incentive, I guess, to say, okay, you know, I know medications can be expensive, so if we enroll you in this program, you are eligible to receive this funding. Previously used to have to do the little CTG annotation on scripts. That is now gone. If the patient is a Medicare holder and they are registered with the program, that information will all be collected and stored in a central data point. And when a pharmacist a script is presented, the pharmacist will know that that patient is registered. So a really beneficial program to those patients, particularly the elderly. With her health assessments, just a bit of a summary. So the nurse's time is counted. So I get a lot of questions about this. Can the nurse's time be counted? Absolutely. So if the nurse spends 30 or 45 minutes with the patient, and then the GP spends 25 to 30 minutes with the patients, you have more than met your 60-minute requirement for the 707. Health assessments allow us a yearly benchmark. So they are best performed every year to allow us to notice when things might be changing. Detects early change. And when they're conducted properly, and by properly I mean passionately, where somebody actually really wants to do it and the patient gets something out of it, it's rewarding for both the patient and a great source of information for the GP. So please, if you are not doing them or have stopped doing them because of COVID, please get going on them again, because they are such a value add to our elderly patients. Hence the reason that most of the health assessments eligibility is for that over 75 group. So now we've talked about health assessments, I think the next step in managing our patients is care planning. So how are we going to manage our patients with a multidisciplinary team? How are we going to identify to them what their conditions are and how they can manage them? So why care planning? Basically, the data shows that multidisciplinary care planning in general practice has been associated with improved outcomes for patients with chronic conditions, especially where there's follow-up. That's really important. So if you are doing care plans just once a year, the patient comes in January this year because they need to get their 5 EP or their 5 podiatry visits or physio visits or whatever it is that the allied health services that they are using. They will come in, they will do what they have to do to get that, then you won't see them again for 12 months. And that does not meet the Medicare requirements. So they must be reviewed at least once in a 12-month period, so at least a 6-month interval. So what I recommend to you, if you are having trouble with patients who are getting what they want, basically not coming back, is don't give them all 5 of them. Say to the patient, I'm going to give you 3 visits to the podiatrist, which will take you up to the 6-month interval, and then you will need to come back and see me so we can review your plan and we can then give you the further 2. Something to keep in the back of your mind. It's a guaranteed way of getting them back. Important elements of our care plan or any kind of management of patients is having a planned framework of care. So something that's documented and everyone knows what they are doing and how they're participating. Regular review is important. It allows constant monitoring of our patients, but it also allows the patients to understand their condition better because they are getting it documented and explained to them clearly. So why care planning? Care plans significantly and substantially increase likelihood of regular contact with our GPs. So it's a really good way of getting our patients managed because we're going to review them regularly. And patients feel and have fed back that they feel they get better quality care and they have an increased knowledge of their condition due to the education and allied health input or other services that they're receiving. So as you can see, it's really beneficial. As with everything, there's barriers and enablers. The barriers to care planning, GP time. So if you don't have a practice nurse employed in your practice, it makes it very difficult for you to manage your time and incorporate these kind of things into your day. So it's a really good business model to employ a practice nurse. And if anyone wants to talk to me about that later, I'm such an advocate for practice nurses. I think they're just the best thing ever. If anyone would like to have a chat about that later, I'm more than happy to help you to move towards employing practice nurses, because that's such a value add to your practice. There's confusion. We talked about before about the fear of audit and the Medicare rules around it. And perfect scenario, they don't believe in MBS care planning because it's a rorting of the system. So there are some GPs who just do not believe in it. They think that I manage my patients quite well. Yes, I'm sure you do, but the availability for actually documenting things and putting process in place is so much better when you've actually got your nurse or a plan in place. It can be complex if you don't have the right tools available, so really easy to use templates are really important. And of course, there's always that factor of insufficient space, so no room for a nurse to interview the patients or the consultants, or no computer access. So these are all the barriers, but with barriers, there's always enablers. And the strongest or highest enabler for appropriate and well-managed chronic disease planning is to have highly motivated and skilled practice nurses. They are the drivers of this whole program. You need to have efficient systems in place as far as templates go, so that you can quickly access what you need and create documents that are meaningful to the patient, that meet the MBS criteria. And of course, communication protocols and roles for your staff. So who's going to follow up the reviews and reminders, and who's going to recall the patients, and who's going to check they've had their pathology before they come in. So you need good systems in place for that. And of course, teamwork. In general practice, teamwork is the only way to go, and we do it really well. So this is just another component of how we manage our patients, by effective teamwork and communication. And you only need to use a few MBS item numbers. So 721, 723, and 707. You have generated a really good income for yourself, but you have put in place all these amazing things for your patients. So it's a win-win. Okay, bit of a overview of just the criteria for what is essential for a patient before they're eligible for a management plan, or a GPMPs, I'm going to call it. The patient must be living in a community with a chronic or terminal medical condition. Don't forget those patients who are palliative or who are terminal. They are eligible for it, and they are probably the ones who need it the most. So there's some of the conditions. It's not an exhaustive list. There are lots more. And basically, I often get questions is this a chronic disease, and is this a chronic disease, and will this qualify? Medicare don't have any hard or fast rules about what is a chronic disease. Obviously, the criteria goes around the fact that it must be something that has been present or will be present for 6 months. So it's either already been present for the last 6 months and is going to continue, or it's just started now, but you know it's going to be present for at least 6 months. So there are the things you need to remember. And the condition, as I said, non-exhaustive. And if you believe that your patient is eligible, so that basically Medicare say, if a practitioner can stand up in front of a group of his peers and provide evidence or support documentation, or just put an argument up as to why this condition should be managed, that's good enough for them. So GPs are very passionate about supporting their patients. So that is something you should consider. It doesn't have to be something on that list. The chronic disease, the GPMP is a plan purely between the GP and the patient. So there are no other providers involved. It's just something you put in place between yourself and your patient. And it is agreed, and both the patient and the GP agree and manage on long-term goals. The goals should be set by the patient. So the patient should have the opportunity to say, this is what I would like to achieve from having this plan in place. The GP obviously will guide the management, but the patient's perspective is so important. Please don't forget that. You should be asking your patients, okay, Wendy, I have you here for this, this, and this. What do you want to achieve? What is most important to you to manage your condition? Why do you want to manage it? You'll be surprised the answers that you get. Then we have the team care arrangement, which is part 2 of this. So the management plan can be done on its own. The team care arrangement can be done on its own. However, they're normally done together. So with a team care arrangement, it's basically the GP coordinating a multidisciplinary team to care for their patients. So there are more than one provider. It involves the GP collaborating with other participating providers on what's required, and the patient agreeing to arrangements with the patient and documenting the arrangements. We could talk for hours about this, and there's I know I can already hear the questions coming about collaboration, so we will touch on that a little bit later if you'd like to in the Q&A, but because it's quite complex. But basically the other providers must agree to participate in the care of this patient, so which means that we have to contact that provider and ask them to participate. How you go about the billing and things is just a whole other story, but we can talk about it later if you'd like, because we will have some Q&A time at the end. And of course, as with anything, you must provide copies to the relevant providers along with a copy to the patient so they know who's doing what. Claiming frequency. So as you can see, now, what I would also like to stress here, if we are concerned about Medicare and doing the right thing, the recommended frequency is 2 yearly for a management plan, but the minimum claiming period is 12 months. However, if nothing changes for that patient, so a management plan is put in place today and 3 years later, nothing has changed and that patient is still being managed under the same care plan, they should not have a new one. So just because we've met the 2-year mark, it doesn't mean you automatically have to do a new one. Sometimes, however, on the other side of the coin, if something changes significantly 2 months after you put a care plan in place, you can do a new care plan. So even though there's a minimum claiming period, there is always the exception. So perfect example is a patient who you're treating for chronic back pain. So they have a care plan in place and a team care arrangement, and then a month, 6 weeks later, they are diagnosed with a palliative condition, so cancer or something significant. There's been a significant change in their health. You can then recreate a care plan because everything has changed. The care providers are going to change and the goals are going to change. So you can do it, but you must annotate it as exceptional circumstances. And it should be a significant change in the patient's history or in the patient's care condition. Then you have your TCAs, which again, same claiming interval, and again, same rules. If nothing changes, you shouldn't do them every 12 months. And then you have your reviews, which obviously 6 monthly is a recommended, minimum is 3 monthly. And then you have your other services like your contribution to another provider's care plan. Now, a lot of people ask me, what is that? Basically, the best example I can give is palliative care. So when you are managing a patient and you are and the palliative care team have taken over the care of your patient, and they ring you as a GP because they need a drug, they need an order over the phone, or they want your advice about the patient, you are then contributing to the palliative care team's care plan, so you can then charge the 729. And again, every 3 months is a minimum. If, however, you have done a review of a management plan 2 months ago, you can't do the 729 because it's still that minimum requirement. So it has to be 3 months between any of those item numbers as an absolute minimum. And then you have your contribution to your aged care facility care plans or the item 731, which again, GPs are really bad at doing, or my GPs are anyway. So you go up to the residential aged care facility regularly, you review your patients or your residents. How many times do you bill the 731? I'm tipping there's a lot of you that are like, what's a 731? So something to talk about later, perhaps. Practice nurses, as I said, strong advocate for practice nurses. Practice nurses can contribute to these by actually providing a service for the patient. So they can actually act on behalf of a GP and provide services. So measuring blood pressure, ringing when there's my practice nurses do things like they do blood pressure. They will also ring patients if they've had a change in their medication. We may have increased or decreased their blood pressure medication. The GP wants someone to touch base with them tomorrow just to check that they're not having any any postural drops. So they're the kind of things that practice nurses can do. So don't forget about that, guys. There's lots of things the nurses do for you every day. And if your patient has a care plan in place, you can bill that 10997. So the services provided, and then you've got your management plan, team care arrangement, and multidisciplinary. So these are what the practice nurse can contribute to. Now, the important thing to note here, and I won't drag on too long with this, but if your patient has a care plan in place for diabetes and the practice nurse is taking a splinter out of their finger, that is not, you cannot bill 10997. The 10997 or the practice nurse contribution should be a contribution to the care of their chronic condition. However, if that same patient was seeing the practice nurse for a wound dressing for a diabetic ulcer, then absolutely you can bill the 10997. So the service must be consistent with the care plan or team care arrangement, what it's in place for, basically. So just so you can see, the 10997 is worth 12, I think it's actually $12.50. I have updated it. And the nurses can check on the clinical progress, so they can make a phone call to the patient because they are under the guidance of a GP. They can check medication compliance. They can offer self-management advice. So device techniques on using inhalers or spacers, and they can also collect information to inform the GPs. So value add to the practice, and the 10997 is again one of those item numbers that gets under resourced. Now, just some billing restrictions for you too, and I'm sure you're aware of it, but if you're not, I'm going to tell you anyway. 8 years ago, the government or the MBS stipulated that a GP who was conducting chronic disease management, so a 721 or 723 or GPMP TCA, they cannot claim a standard consultation item number at the same time. So if you're seeing a patient for new plans, you can, and then they say, oh, by the way, can I have a script for something else? Or can you check this splinter in my finger? You shouldn't bill any other item number. However, if you have seen that patient and the patient gets up to leave and collapses, or the patient has some kind of acute episode, then by all means you can bill an item number. So you don't expect it to happen, but if it does, don't be worried. What can I, can't I? Yes, you can, but it has to be an acute episode completely unrelated to the reason the patient presented to the practice in the first place. And your general consultation item numbers are things like your standard item numbers and your after hours item numbers. So that's the rule, but there's always exception. However, it's still fine to bill a care plan and a health assessment together. I wish I had $1 for every time someone has said, I didn't realize I could do that. Absolutely. You have always been able to bill health assessments and care plans together on the same day. You can bill a care plan and a mental health treatment plan. So if in the conducting of your management plan, you identify that patient has a mental health condition that needs support, you can then put the mental health plan in place and you can bill a mental health plan as well. It's all about the way you bill it and how it's annotated so that Medicare don't reject it. And you can bill health assessments and mental health plans together. So what I've done to aid you is, and this, you will be getting a PDF of this presentation, so this will be available to you, is basically a review, a sheet of what you can and can't bill together. So down the left-hand side lists all of the item numbers available to general practice that doctors also often say, can I, can I? And across the top is either a tick or a cross. So basically the only ones you can't bill are these first three columns. You can't bill standard consults with any of these three, okay? So available for you to keep and to use as a resource if you like. So obviously with the elderly Australians, mental health with COVID-19, as I said before, has been significant. So I would like to touch on the components and criteria for mental health plans. It's basically a program called Better Access, and it has been implemented to improve and manage the mental illness within our community. And as we know as practitioners, it's just escalating. So mental health is becoming more and more of a burden on the health system. The aim is to provide patients with access to mental health care that's appropriate to their level or to their needs. And there are Medicare benefits available to the patient for selected mental health services by GPs. So any GP who does their focused psychological strategies can bill an item number. You also have psychiatrists, clinical and registered psychologists, and of course, appropriately trained service workers and OT if you are referring to them. So they are who can provide services under a mental health plan. Services under Better Access are available to patients in the community and private inpatients, including residents of aged care being discharged. So if you have an inpatient in hospital, so if you are one of those GPs that actually sees patients in hospital, so your clinic or your co-located, or you have an agreement with the hospital and you go to the hospital to see inpatients, they can be billed there, and they are available to patients in the aged care if they are not funded. So if a mental health plan is put in place for your residents, then you can certainly put in, they can access those services. To be eligible, the patient must be assessed as having a mental health disorder. The referring health professional is responsible. So it's, as GP, it's your responsibility to diagnose the mental health condition and refer that patient to the appropriate services. Don't forget, we still have the temporary COVID-19. That word temporary has been around for 2 years. Telehealth services, which are available for both phone and telehealth. So don't forget about those, but they can only be used when there's an established clinical relationship. There's no standard referral. You can use your own template, so just a letter, but you must always supply a K10 or a DAS21 with that. Plus, your letter should include, so these are the criteria, I guess. There's no specific referral, but your referral must include the patient's symptoms and the number of referred services. How many times have you got feedback or a letter back from a psychologist saying, how many sessions are you referring for? It is mandatory when you're referring to the Better Access program that you list how many sessions you are referring for. You must provide the practitioner with a copy of the mental health plan, and the initial referral can be not for more than 6 sessions. So you cannot refer on the initial referral for more than 6 sessions. So you can't say 10, you can't say 8, you can only refer up to 6. Then you'll review the patient's mental, after you've received feedback from the treating clinician, you'll then review the patient's condition or how they're going, and then you can then refer for a further 4 if you feel it appropriate. And once those 4 have been completed, you can then refer for those additional 10, which is what we have available for the COVID-19. So there's still those item numbers. And at this stage, they are still available till December 2023 to be reviewed then. So let's watch this space. Obviously, more for if you have allied health in your practice, the 10 additional item numbers for COVID-19 have a different item number. So when a practitioner, often we get psychologists saying that the patient's plans expired because they can't claim the additional 10. It's usually because they are not claiming the right item number. It also allows the patient access to 10 group services, and these are limited per person and they are per calendar year. So 1st of January to the 31st of December, 20 in total. At the completion of the first 6 sessions, a written report must be provided to the referring practitioner. Doesn't happen, does it? Some psychologists are really good at feeding back and some are really bad. So it's hard for us as practitioners to continue to refer patients for services when we are not receiving feedback. So you need to get onto those psychologists, psychiatrists, whoever they are, and say, you are not meeting the MBS criteria. You must be providing me with feedback. Brief overview, but I really want to spend some time on case conferencing, so I'm going to keep going. Other programs that are available to us to manage our elderly patients, as I said, medication mismanagement is one of the high risk factors for hospital admission. So these are something, again, that we don't do that well, but we should consider implementing in our practice. So to be eligible for it, the patient must be living in the community. Obviously, residential aged care facilities have a separate item number and a separate process. The patient must be at risk of or experiencing medication misadventure. So as a GP, you're going to say to yourself, look, I'm a bit worried about the way this patient's managing their medications. I'm going to actually get a medication review done. The criteria states they must be on either 5 or more medications, 12 or more doses, or be significantly confused about what they're taking, basically. So if you've got patients who are on multiple medications and during your interview with a patient or when your consultation with a patient, you think they really don't know what they're taking or they're confused, that's a bing, a light in your head to say, I need to refer them on, particularly when there's been significant change in their medications as a result of a recent hospital admission. So a patient who has been admitted to hospital and who has had lots of medication changes, they are the perfect candidate. Remember also, if our patients are seeing specialists, there is a risk of those medications, they have also changed their medications or added a medication. And because the feedback or letters from specialists can take a little while, sometimes patients can be experiencing symptoms from medication that's been introduced that we don't know anything about. So it's a really good opportunity to put that in place. The other thing that I'd like to touch on is the DVA treatment cycles. Again, something that general practice is not really, has not really grasped onto. I'm surprised it's still actually around. So basically, this was introduced in October 2019. And the short version of this is that it allows anyone with a gold card to access multiple allied health services. In fact, you could almost say unlimited allied health services per year. So what it does is it creates cycles. So to put in perspective, if you have a resident or a patient, here goes that resident again, if you have a patient who requires physio, podiatry, dietetics, exercise physiology, OT, all of those things to actually manage them, each of those allied health providers can be referred a cycle of care, which allows them to provide 12 services of their undertaking, and then they can continue that. So one person can have 6 or 7 different cycles of care for different providers in place. So they could be receiving cycles of cares from podiatry, exercise physiology, physio, all of those things. And once those first 12 visits have been finalised, the allied health provider must send back a letter to the GP. It's actually like there is paperwork. And then the GP can say, yes, I think you've really improved. Your sarcoidosis has actually is much better or is improving, or the side effects of it are improving. I think it would be a benefit for you to continue with the physio. So I'm going to refer you for another treatment cycle. It's just a DVA referral form. It's really great. I have put a link at the back of this. And again, if anyone wants more information, please feel free to contact me. I'm happy to support these kind of programs. As I said, a care plan must be created and an end of cycle report must be provided to the GP. We're as bad as everyone else. We don't do them as often as we should. We have quite a few gold card holders. I think we have about 95 of them, and probably half of them have got treatment cycles in place, but the other half are enrolled in the CVC program. So this one is a great service to those beautiful elderly patients. So anyone with a gold card is eligible to be enrolled in the Coordinated Veteran Affairs Care Program. That's what CVC stands for. So they basically, the only criteria, I shouldn't say everyone, because the actual criteria is that they must be at risk of hospitalisation. So DVA are very good at highlighting for you which patients you should be enrolling in this program. Basically, it's only available to gold card holders, regardless of their age, who are at risk of hospital admission. So it could be a young gold card holder who's returned from Afghanistan, is now experiencing PTSD, for example, and is having multiple hospital admissions because of that. It's a practice nurse-led relationship. However, it doesn't have to have a practice nurse. So there's basically 2 areas: with a practice nurse, without a practice nurse. So if you are a solo practitioner with no nurse, you are not excluded from enrolling your patients in this program. And basically all it involves, apart from the normal chronic disease management we provide to our patients, so care plans and health assessments and all those other things, all it involves is the nurse making a monthly phone call to the patient to touch base. How are you going? How did you go with your last appointment? Do you need any help with anything? Do you need any transport organised? And documenting that she has spoken to them. So it really builds a beautiful relationship between our practice nurses and our DVA gold card holders. And the benefits financially to you as a practitioner or as a practice, the UPO1 is the initial enrolment. So you are paid $448 to enroll the program or the patient in the program. That's a once-off payment. And then you are able to bill a UPO3 4 times a year. So every 3 months you can bill a UPO3 on top of everything else that you can bill. So it's like that incentive. So it's quite attractive financially or remuneration wise. And those gold card holders do, they are the ones that we like to spend our time with, or they take a lot of our time. So please keep that in mind if you haven't. And again, there is a link in the PDF if you would like to look more into it, or you'd like more information. Very, very valuable. Now, the most important thing about tonight's session, I believe, is case conferencing. So we've identified that we have got a lot of our patients who are at risk of hospitalisation, or that they're frail, or that they've been isolated, or they've got chronic conditions. How do we coordinate it? So we put all our wonderful plans in place. We've sent off referrals to all our treating practitioners and our allied health, and everything's on the go. But how do we communicate? The best, most effective way for the practitioner, the specialist, and the patient is to do case conferencing. It's a valuable tool in communication. It's informative for everyone. So when it's conducted properly, you have everyone in the same room, whether by face-to-face or via video, and everyone is on the same page talking about the same person. It's convenient, and there's minimal travel required. For a practitioner, there's no travel required. But for your patients, they only have to come as far as they have to travel to the clinic, and they have the support of their GP, or the practice nurse can be involved to assist them in understanding what the specialist is talking about. You can either organise a case conference, or you can participate in someone else's case conference. So there are 2 areas as far as case conferencing go. Normally we participate, a specialist contacts us and we participate in their case conference, but you can organise one yourself, and that's where it becomes part of your practice on good coordination. And the patient does not need to be present. So you can actually have a case conference about a patient without them being present. Obviously, if they have dementia or have other issues, it's not always reasonable or viable to have them there, but they do not have to be present if you'd like just to touch base with the other people, particularly if there's been a significant change in the patient that you're treating. And now allied health can be remunerated. So as of November last year, any allied health practitioner participating in a case conference can now be remunerated for their time, whereas previously they gave it up out of the goodness of their heart just to coordinate the care of their patients. So to be eligible for a case conference, again, the patient must have either chronic or a terminal condition that requires the input of multiple service providers. There must be at least 2 other providers. Now, this is always a bone of contention here. What classes as a 2? So GP is 1. You can include another GP if they are providing a different service. So the best example of that could be focused psychological strategies. So the GP is looking after the patient with mental health concerns, or it could be that they are providing acupuncture for chronic pain. So if you have another GP who is providing a completely separate service, they absolutely can be included. The practice nurse can be included if she is providing additional services, so ongoing wound management or education. But the other 2 providers can be any of those following. So allied health, specialist, community services, so even things like Meals on Wheels, any community health services can be included. Another GP or practice nurse providing an alternative service. Families and carers can be present, but they do not count towards the minimum number. So you could have the daughter and the brother and the sister and the uncle and the auntie, but they are not counted. They are basically there to provide information or support their parents or their loved one. And as I said before, the patient does not need to be present. If you organise a case conference, basically they're all about time. So these are the item numbers you would use. You would use a 735, 739 or 743, and I'll show you the remuneration a bit later. Or if you're participating in someone else's case conference, you have 3 item numbers as well. And again, they are all time-based. So please start your notes as soon as you start the consult, because the time, what you can bill Medicare is reflective of the time that you spend with the patient. The process of case conferencing is the same whether you participate or organise. The patients, then you must discuss the patient. So the patient's history, getting everyone up to speed with it, identifying the care the team and then the care that's provided, and identifying outcomes. So what do we want to achieve from our case conference today? What will be like for our patient to achieve? And then you need to identify who's going to do what. So basically, at the end of your case conference, everyone goes away with their knowing what their role in that was, what their outcome is, and how they're going to participate moving forward. So as you can see, it's a really functional way to coordinate the care of your patients, and everyone's on the same page. And then obviously look at, did we achieve the outcome from the last case conference? If not, okay, what are we going to do to change that? When participating in a case conference, the GP must always explain the nature of the conference to the patient. So before the case conference starts, the GP must explain what you'd like to achieve out of today's conference and why you're having it. And of course, obtain and record the patient's agreement to participate. You should also record the details of the actual teleconference. So what date it was, who was in attendance, and all the matters that were discussed. So it is time consuming, and this is allowed in that claiming period. So if you're on the actual webinar or case conference with someone for 10 minutes, but then spend another 20 minutes actually recording everything, that time can be counted. And you must put a copy of this in the patient's record. When you organize coordinate a case conference, the GP must do all of the above. I think I just did that twice, didn't I? Sorry about that. So case conference and co-claiming. You can co-claim with a health assessment. So if you've got a patient in and you're conducting a health assessment and then a case conference is booked for the same day or the same time, you can absolutely bill both item numbers. You can also bill that with a standard consult. So the patient is there for their case conference. After the conference is finished, the patient then requires additional service from you. You can absolutely bill that. However, but you must meet the MBS requirements of both, but you cannot bill a case conference on the same day that you bill those care planning item numbers. So again, there's always those restrictions around your care plan item numbers. And as I mentioned briefly before, as of the 1st of November, Allied Health are now able to bill their time, to claim their time for Medicare for participating in case conferences. The patient must be managed under a multidisciplinary care team, and the case conference must be instigated by the GP. So the Allied Health provider cannot instigate it. The Allied Health provider can request it or mention that it would be beneficial, but they are not the instigators. It must come from the GP. And the no existing relationship rule doesn't apply here. So the case conference can be conducted without the other Allied Health provider knowing the patient at all. So that's a real bonus, particularly when you want to do new referrals. They can be conducted every 3 months. And as we said before, with any case conference, there must be 2 additional item numbers, 2 additional providers, and they can be by telephone or telehealth. So if you're not using them, that's the remuneration. So the top 6 numbers are the GP remunerations. The bottom 3 numbers are the Allied Health remunerations. So as you can see, about 50% of what we get, but still they weren't getting anything before. So it's certainly a reason to start encouraging Allied Health to participate. Obviously, there are barriers with everything else. Often practitioners are reluctant to bill when the patient's not present. So if you are conducting a case conference without the patient, practitioners often get a little bit antsy about billing that. Scheduling is so difficult. So unpredictable workload. You could have a case conference booked and then the day goes to dirt and you're an hour behind. And so therefore the unpredictability of both yourself and the other people participating, particularly specialists, they are known to be running behind. So it's really hard to book those in at a time that works for everyone. There's always going to be those issues. There's always that perception that face-to-face is of greater value, and differing work, as we talked about before, differing work practices, so related to the times of the meeting. One practitioner, so my GP might only work Monday, Tuesday, Thursday, and the specialist might only work Wednesday, Friday. So we have to try and coordinate that when we can both get them on there. And of course, success always depends on the personality of those participating. I won't say any more about that. The benefits, of course, are huge. Improved coordination of the patient's care. Everyone knows where the patient's at and everyone can communicate and talk about what they're doing for that patient. and the provision of efficient service and continuity of care is so important, particularly when we're talking about mismanagement and risk of hospitalisation. So our elderly patients really do benefit from case conferencing. And if you're not doing it, I really want you to start with one, just one, and see how you go. To do that, the best way is, as I said, one patient. Think of someone that you know that you have got multiple providers involved with. So identify the needs and identify that patient and get someone to book a session. Get one of your staff to ring the other specialists, so the other providers, and coordinate a time that suits all three of you, or four of you, or five of you, however many you've got. Book that session in. Try to book it in advance so that you've got a little bit of leeway with your time. If you try to book a case conference for next week with your diary being full and the other service providers being full, you're never going to make it work. So allow some time. Go for a month down the track and say, let's coordinate this and book it in. Yes, we can all agree on that time. It does take a bit of toing and froing to get the right time, but it is so worth it. Just one person. The patient must consent to it, of course, so you need to obtain consent. You need to decide on the modality, how you're going to deliver it. Is it going to be a face-to-face because you have the diabetes educator and the dietitian and the podiatrist all in your practice, so you can get them all together and do a face-to-face version? Or is it going to be via video because all of these service providers are not within easy reach? Who's going to remind everyone? Make sure that there's someone who's going to remind all the participants about that upcoming case conference. So we can put it in our calendar. It's okay for us. We can put it in our appointment book and we know it's coming. But who's going to remind those other people? And who will facilitate it? Someone needs to take responsibility. It's normally the person who instigates it that will facilitate it. So that decision needs to be made. These are some suggestions that were put forward by GPs. I am nearly finished. But put forward by GPs to assist. So they want simpler MBS procedures and item numbers. To encourage GPs to do this, we want things simpler. They want your introduction of specific item numbers, particularly for things like palliative care. GPs need to be consulted when there's changes made to any program, and they want to be able to organise things that are effective and flexible, clear objectives, and make the process flexible. So that would be the perfect scenario. And this is feedback from GPs to the RAC GP. In a perfect world, yes, but like I said, please just try one and see how you go. So just to finish up, as what I mentioned earlier, this the Northern Sydney Collaborative has got some is proactive and timely in connecting services to your patients. So what they do, the collaborative is available to give choices to where the care is provided. And there's two services available, which are still sort of in the development stage. They are up and running, but there's still work to be done. And that's the geriatrician outreach program, which increases these increased specialist input into GP-led planning and care for the frail and elderly, and the health navigators, which are there to support for healthcare professionals to troubleshoot and coordinate care. Basically, the health navigators are a free 1-800 number that you can phone, and you will get the help from someone to find the right local service. So how difficult is it to find a service sometimes? You're looking for a speech pathologist, or you're looking for something and you're like, where do I start? Everyone that I know has got waiting lists, 6 months long. How am I going to find the appropriate service for this patient? So they are there to assist you. They are available to general public, so the general public can ring themselves, but they basically are there for you to find local health, aged care and social services. So please, if you don't know about them, contact the PHN. They will happily provide you with the information you need. And the second service, of course, is only available to 3 regions at the moment, and that's the geriatrician outreach program, which is available to patients to access geriatrician support. Again, please contact the PHN. They've got some great information. It's a great program, and I think if you get engaged, it would be really great. So, ladies and gentlemen, in summation, general practice is in the unique position to support our elderly Australians by preventing avoidable hospitalisations with a planned structure of multidisciplinary approach to their healthcare, actively engage other care providers to link appropriate services that will enhance both the quality of life and their continued independence. So I'm going to now thank you very much for sharing your time with me. I'm going to stop sharing my screen, and I'm going to invite Hoda to come back on and tell me if there's any questions.
Many questions, but thank you so much, Wendy. That was really informative and comprehensive. Many questions. I'll just start from the top. Would you bill 721/723 if a patient has a group of GP, practice nurse, specialist, or allied health professional?
Sorry, can you read that again? Will I bill 721/723 if the service providers are?
Oh, yeah, it says if a patient has a group of GP/practice nurse/specialist or allied health professional.
Yeah, so with the 721/723, the only thing I will remind you is it can only be one specialist. So a patient might have, let's use a diabetic, for example. They may have an endocrinologist and an ophthalmologist and any other service providers that are specialists. Only one of them counts towards the 3. So GP's one, specialist is one, but they recommend there should be an allied health provider as well. So those 3 services should be made up of 1, 2, 3, 1 out of each group. There can be more than those involved in the care, but that is a minimum. I really hope that answers what you were asking.
For that participant that put up that question, if you have any other follow-up questions, please put that in the chat. The next question is annual frequency. Is that a calendar year or from the time of the health assessment?
12 months from the date. So if you conducted a health assessment today, the 19th of October, they cannot have another one till the 19th of October, 2023.
Wonderful. Next question, can you recommend a health assessment template and what other tests should be included? Examples, depression scale, frailty, cognitive tests?
I can absolutely. I will send through to Hoda the template that we use, which I have spent a lot of time creating. And it links to, it has the K10, it has the DAS22, all these things can be added to it. And it basically goes through every requirement. So if you complete the template, you have ticked all the boxes for Medicare. I will send that through tomorrow. Best practice medical director, I'll send it in both.
Thank you. Do nurses assist with your health checks as well?
As in the 699s, so healthy heart checks? Absolutely. So the nurses do the same thing, but they only spend 15 minutes with the patient, and then the GP spends the other 15 minutes. So we tend to focus more on our health assessments because we have got, with COVID, we got so far behind with them. But yes, absolutely. Nurses are great at all that kind of things, and they're really structured and organized. So they are the ones you really need to get you to assist it. And as I said before, if anyone doesn't have a practice nurse, those solo practitioners, I understand that there are a lot of small practices, or there may be solo GPs present tonight. The actual business model or the business case to have a practice nurse is really inviting and really, really worth considering.
Yep, definitely. So should nurses not be writing the GP management plans or team care arrangements for GPs?
Good question. So the nurses can create the care, they can create the template, but the goals is what is the only part the GP really needs to sit with the patient and ascertain. So the nurse can populate the data and ask questions and fine tune where they're at, but the GP and the patient should be setting the goals. They should not be generic goals. So I hate it when I see a care plan that has for diabetes, maintain HbA1c less than this, blood pressure this or this, exercise regularly, eat well. No, the goals, they are the best outcomes, but that might not be important to the patient. They might not care whether HbA1c is less than 7, but they might want to be able to walk far enough to take their granddaughter for a walk, or they might want to be able to travel, and to do that, they want to lose a bit of weight, or they might just want to look better for their wife. All those things might sound trivial to us, but they are the reason that those patients want to participate. So the goals should always be set by the GP.
Great, thank you. Medicare rejects 732s submitted if the 721, 723 are more than 2 years old.
No, not in my case, they don't. So
Okay.
if the care plan, there is no reason. So I I have one, I can think of two off the top of my head who have not had a new 721 and 723 for 6 years. And every 6 months they are reviewed. Nothing has changed. We continue to bill the 732s and they continue to pay them. So it might be worth questioning Medicare why they're rejecting them, because that is absolutely not, shouldn't be the case.
Okay. So does that mean we can't claim another GP management plan if patient's T2DM is well controlled?
Yes. So doesn't say you can't. Let me clarify that. You can, but you shouldn't, basically. So the guidelines, if you want to follow the Medicare rules, Medicare guidelines state that it should not just be an automatic every 2 years do a care plan. If there is absolutely nothing that has changed and that patient's type 2 diabetes is completely controlled and well managed, there is absolutely no reason to create a new plan.
Great. Thank you. Do you have to see the patient in person to bill the 729, 731 if called on the phone?
With the 729, no. So if it's a palliative patient, for example, and you're talking to the district nurse or the palliative care team who are ringing you to ask you to engage in the participation, or probably the perfect example is the PAL care team drops in because they want you to write up drug charts and they want you to discuss the patient with you. No, you don't need to see the patient. However, the 731, which is the review of the care plan in the aged care facility, yes, you have to have seen the patient. If that patient has dementia, you don't have to sit there and discuss it with them, because what you're doing is actually documenting in the residential aged care facilities care plan your input. So you should have seen that patient so that you can actually put a up-to-date input in there.
Great, thank you. Can 729 be claimed without talking to the patient if GP consulted with another health professional?
No. Oh, go back. Sorry, the 729. Yes, so I think we just answered that.
Yep.
So
okay. Sorry. Yep.
729
Okay.
can be claimed without seeing the patient, basically.
Great. Is the 10997 not in person only, not telehealth?
No, it can be the nurse can ring the patient and say it's basically about instruction from the GP. So it doesn't have to be in person. It can be a phone call to check on the patient's medication compliance, but it must be directed by the GP. So GP must say to practice nurse, can you ring Wendy or Amira, please? And I've started on a new medication for her diabetes yesterday, and I want to make sure that she's okay with that. That is all you need to do. That's the criteria met. And the 10997 can be backdated. So if you get towards the end of the year and you think, gee, we haven't had to use this, and I can think of half a dozen patients that my nurse has been regularly looking after for me, you can go back to those dates and backdate the 10997s if you'd like.
Great. What services can you provide to white/orange DVA card holders?
Same as Medicare. So basically white and orange don't have that gold card status. So basically any other service that you would provide to a Medicare patient is the same for the white and gold. There's no actual special services. They're not entitled to the CVC treatment cycles, the DVA treatment cycles, the CVC program. All of those are purely just the same as if they were on Medicare.
Great. What is UP01/03?
Yeah, it's a nice number. It's like a 23 or a 10997. So UP01 is the enrollment of a patient into this CVC program. So that's billed once, and the remuneration is $448. The UP03 are the 3-month intervals. So UP01 first, UP03 every 3 months. You can then bill another item number. So I have them in my diary. For example, all my UP03s are due to be billed tomorrow. So I will go through all my gold card holders and check all their files, and I will bill all of my GPs the UP03s. Great.
How do you refer for the CVC service?
Yeah, so there's no referral. You just have to get the patient to enroll. So if you'd like, Hoda, I'll send you like a link to the resources, but basically there's no referral pattern. It's basically you saying to that patient, I really believe that you would benefit from being enrolled in this program. My nurse is going to call you every month and check on you, and we're going to do health assessments and care plans. And so there is CVC paperwork. But once they're enrolled, it basically just rolls over every year. So there is no referral process. It's about identification of that patient's eligibility. If you get the DVA Veterans Mates, which is a newsletter that's sent to GPs who usually they throw them in the bin, read it next time, because it actually will identify to you which of your patients may be risk of hospitalisation.
Okay.
And they're the ones you can enroll.
Great. Any recommendations for a case conferencing platform?
I so love face-to-face, but Health Direct, so the Health Direct video calls, Zoom, Teams, anything. There's no, we are talking, okay, it's probably a good, I probably should stop there and say that should be encrypted or it should be safe. So we shouldn't be probably using Teams, but the Health Direct, the video link is the perfect platform, free to general practice. If you're not aware of it or don't use it, contact the PHN, because I know that they offer it to you. It costs you nothing. And we use it for our health, for our appointments. So any video health, we do that way. We used to use Zoom, but then patients have to have a Zoom account, or they have to have a Teams account, or they have to have a go-to webinar. With Health Direct, you don't have to have anything. You send a link to the patient's phone, they click on the link, and they are there waiting for you when you go in. So if you don't know about it, contact the PHN, because it's fantastic.
Yep. Does a case conferencing billing include time for documentation?
Yes. Well, as long as the patient's still there. So if you conduct your case conference and you've spent 15 minutes on the webinar or the system, and then that case conference completes, and then you spend more time with the patients explaining it to them and coordinating things, then all that time can be counted. Absolutely.
Great. Can the practice nurse count as a member of the team for the purpose of a TCA?
Only if they're providing a separate service. So as a rule, they shouldn't be. Often we can sort of stretch it a little bit. So for example, if a patient has diabetes and the nurse regularly reviews that patient because they have chronic diabetic ulcers, or the nurse does their blood sugar for them regularly, or any of those things, then she's providing a separate service. So yes, but as a rule, if you want to be completely compliant, no, they shouldn't be included. They should be included in the team environment and included in the conference, but they won't be included as a number.
Okay. To confirm, nursing time counts to the 20-minute for a healthy heart check.
Yes, absolutely.
To clarify, can 729 be claimed for discussing with a specialist / community nurse doing dressings, etc.?
Yes, it can. Because as a GP, you are telling that community nurse how you'd like that patient managed. So you are participating in their care plan. So they have a care plan in place with how they're going to manage it, and they are asking you for your input into that. We have this problem. How would you like us to manage this diabetic ulcer or this chronic wound? Your input is exactly the same as if you would in a nursing home or any other provider participating in a care plan, basically. It's just unusual for us to be on the other end. We're normally the ones creating the care plan, inviting others to participate. This is the other way around. Someone else has a care plan and inviting us to participate.
Great. Is there a limit on how many 10997s are billed in a year?
5.
5.
5 per calendar year. So January to December.
Who would you bill the 10997 to if the GP has requested a nurse to call their patient?
The doctor. So if Dr. Smith said to Nurse Wendy, can you please phone Mrs. Harris because I want to check on something, then the 10997 would be billed under Dr. Smith. Because Dr. Smith is ultimately responsible for what I do. So I'm working under direction of Dr. Smith.
Great. Do you need to see the patient to bill UP01 / UP03, or do you just do it automatically?
Automatically every 3 months. So because the care's been provided, so it's like an incentive almost. It's like every 3 months you can bill this item number, but when you bill it, you need to go, okay, yes, The nurse has rung the patient every month, so all the criteria has been met. But no, you don't need to see the patient on the day that you bill the UPO1 or UPO3. Ideally, with the UPO1, you should, because you'll be enrolling them on that day, so they have to be there. So you would bill the UPO1 plus your health assessment, plus your care plan, plus anything else you decide to do. And then the UPO3s will be billed 3 monthly after that.
Perfect. 2 more. Once enrolled in CVC, what services do you have to provide to then claim the UPO3?
So it's about support. So practice nurses are so vital in there. So you basically, when they're enrolled, you need to ensure that they have, so they're socially, that there's a social component. Are they socially active? Are they isolated? If they are isolated, what programs can you refer them to or encourage them to participate in? But basically nothing more than a monthly phone call and coordinating anything that they may need. So basically they should have a straight line to the practice nurse. They shouldn't have to wait. If they ring and Nurse Wendy is my nurse and I ask to speak to Wendy, I should be put straight through to Wendy. And if Wendy's not available, Wendy needs to ring me back. That's the commitment we make by enrolling this patient. They commit to coming and seeing us and letting us know when things are good and bad, but our commitment is to ensure that we touch base with them and that they have an open access to the nurse who is looking after them.
Great.
So it's probably not a good idea to enroll them and use a nurse who works 1 day a week.
Yep. Just to clarify, GPs can't claim TCA if involving 2 specialists rather than 1 specialist and ally health professional.
Correct. Absolutely right. So if you're doing a TCA and the patient sees an endocrinologist and an ophthalmologist only and no other allied health, no, they can't include. If, however, they see an endocrinologist and a podiatrist and a diabetes educator and a dietitian, all of they can be included, and it's still that those 3 minimum are met. So 1 specialist only.
Perfect. Okay, I think that is all. Just to give a quick reminder that tomorrow we will be sending an evaluation out to all the participants, but if you have your phone handy, please fill out this evaluation via the QR code now. But I'd like to say a big thank you to you, Wendy, for a really informative and comprehensive webinar. We have been recording and will be sending out the slides out to everyone. And on behalf of everyone, a big thank you for your time.
You're welcome, and thank you all for giving up your time to spend it with me.
Thank you all. Have a good night.
Good night.